Okay. You know about ankle fractures. Percival Pott described it in himself, he had an open fracture. Dupuytren got into the act. Maisonneuve was doing experiments to prove that rotation had nothing to do with ankle fractures, and so he's got a rotational injury named after it. Tillot Chapert, the Fort Wagstaff, are all interesting fractures to be names to know. And Volkmann, of course, was in on the act describing the posterior malleolus and the bloody things gone west. Righto. That's what I did. Henderson's classification, uni by trimalleolar, actually is predictive of outcome more than any other classification. The Lange-Hansen, I've never really got to grips with, and everyone seems to understand Danny Weber classification of A, B, and C. What are the goals of treatment? To restore congruity and stability. Absolutely, although Michelson seems to muck the names up. What are the things to consider? The lateral malleolus, the deltoid ligament, the syndesmotic ligaments, and Volkmann's tubercle. We saw this earlier on. Study by Yablon out of the 70s saying it is extremely eloquent to produce a congruent joint. Otherwise, there's abnormal force and a degenerate joint was resolved. Indicators of stability. The very high fracture is usually unstable, but not always. It can be produced and not disrupt the medial collateral ligaments. Principle of management, AOC. Many fractures can be properly managed closed. Match the personality of the patient. Restore length, restore congruity, rigidly internally fixed, rehabilitate. It doesn't always work. This is a well-fixed, or was a well-fixed fracture in a diabetic. It didn't unite. It ended up needing revision fixation, bone grafting, OP1, and a bone stimulator. This fellow presented with a flat foot. Interesting x-ray to show a nicely displaced this injury. Now, this lady's a diabetic who's been in hospital in the Epworth Hospital under the geriatric unit for 14 days with an ulcer, and a fracture was recognised by the plastic surgeon who was asked to skin graft the ulcer, and he saw some bone. These things a bit abnormal. These are different. So these fractures, these are behaving differently to your routine ankle fracture, which basically, if you operate on it, works. The difference is neuropathy. This is a nice lady in Atlanta. She has a classic Jones fracture. It's diagnosed and recognized. It's put in a cast. So that's week 1, week 4, week 8, week 12. Well documented disaster. She presents like that. This is a Charcot joint, neuroarthropathic joint, a fracture involving a joint. And there's all sorts of classifications of Charcot neuropathy in the foot. The ankle does really, really badly. That's what we did to her down the track, incidentally, when swimming. It's called Charcot disease. Charcot was a brilliant speaker. He ran a hospital in Paris. When he retired, half the patients got better and went home. He attributed the first description of this disease to Mitchell, who worked in Philadelphia. There's a chap called William Musgrave, who's a POM, and he wrote about this in Latin in 1703. It's been well described well before Charcot got to it. Eliza was a fellow working towards the end of the First World War, and he was trying to recreate Charcot disease, trying to prove the French idea that this was there was some nutrition supplied by the nerves to bones. And he's working in cats. By mistake, he damaged one of the joints and he produced Charcot joints. He went on to prove that you need not only a de-innervated lower limb, but an injured joint. Harrison Brand worked out what I think is a really good but most unused classification. Why is it unused? Because it's based on lepers. He set up a huge leper hospital in, first of all in India, then in the southern United States. And I've just gone through that. The idea since Alzheimer really has been a neurotraumatic, the German idea, trauma plus neuropathy. More recent times, the ideas of abnormal cross-linking of collagen setting up the disease, and there is some link with more than just neuropathy from the nerve viewpoint. What's the incidence? Up to nearly half of diabetics are neuropathic, up to 2.5% develop neuroarthropathy. If you get it in one leg, you've got a 1 in 3 chance of getting it in the other. This is more common if you've had diabetes for a long time, have renal failure, or are going blind because of your disease. What's it look like? Thick capsule, bits of dead and living bone in it, degenerate cartilage, some of it alive, some of it not, hypervascular. It changes with time. This joint fibrillates, fragments. Really a severe advanced osteoarthritis. How do they present? Swollen, warm, often a misdiagnosis, often an unrecognized trauma, a very minor trauma, often the first presentation of diabetes. It's a bag of bones. This bloke dislocated, it's a very nice fellow, he dislocated his foot. It was warm and swollen. He presented as to, why is my foot so warm and swollen? An unstable bag of bones. The physicians do MRIs, osteomyelitis and osteoarthritis. The patient's on the waiting list to have a pancreas transplant, and you have to biopsy to prove it's not infected. Otherwise, they want to amputate. It's said that if you elevate the foot and it's a neuroarthropathy, the swelling diminishes very quickly. I'm not sure that's true. Eichenholz reviewed, I think it was 150 people, and he staged the disease. He said there's an acute stage where there's gross instability, it's swollen, it's erythema, it's red, it's warm, it's hot, it's unstable. They swing into a stage 2, which starts to coalesce, and the feet swing in and out of this stabilization. Some, not all, go on to become stiff and solid and rigid. And it's very unlikely that joint will again get Charcot disease. The action for this talk, though, is in the pre-stage 1. So it's a fracture in a joint in a neuropathic limb. It's a problem. It's a potentially big problem. Often present with ankle fractures. Do not think that diabetes is a contraindication of surgery. Manipulative reduction, as I showed with old Mrs. Belcher there in the fifth metatarsal fracture, is not a good way to stabilise it. If you're going to operate on them, which you probably should, long incisions directly to bone, ignore the nerves, a lot of care with the soft tissues. You've got to get the soft tissues right. Some of this is applying more to the more advanced Charcot. Get rid of the dead bone. In an acute fixation, that's not true. Yes, use bone graft, then use rigid fixation. The fixation on the left is way down the track from a fracture in a diabetic. It was a significant fracture. We went to town. There's a big screw that's been removed lower down. And on the right, as I was saying earlier, I'm not scared of putting in 2 large diastasis screws with 4 cortices if I think there's instability. It doesn't always work. Particularly if you miss, do get it right. This chap is a 48-year-old party organiser who tours the East doing bar mitzvahs, of all things. He did a bar mitzvah in Hong Kong and tripped up, and 2 weeks later turns up in Melbourne having walked on this injury. He underwent what I thought was anatomic reduction and fixation, and 3 weeks down the track you'll note there's a bone graft being taken from the heel, a bone graft of the posterior malleolus. The posterior malleolus is starting to drift. I haven't got the x-rays before this, which I regret greatly. He goes on, having been immobilised in a cast for 10 weeks, and he ends up like that, but he now is walking in a shoe with an insole, and he's walking well because we immobilised and with an external support for 9 months, which took him to settle down. If that fails, if it starts to luxate, I'll do an extended home perfusion on him, but he won't